So much, Michelle.
Thank you so much, and thank you all for your perseverance, your patience. I'll try to be brief. I'll try to zero in on the beautiful segue that Dr. Harasha has led us to, which is why does childhood obesity cause cardiovascular disease? And we kind of take it as a given, but in fact, that hasn't been so evident, the answer to why that happens. And it is the reason, the rationale for the selective screening guidelines in 2008 telling us to screen children who have a BMI over 95th percentile. But again, why the association is only beginning to become more apparent. The objectives will be to understand a little bit more about the why in our current state of understanding. And to do that, we have to define a different way of looking at lipids and cholesterol. We talk a lot about hypercholesterolemia. We're very LDL-centric. But in fact, the disorder of obesity is not a high cholesterol disorder. So it's better referred to as a dyslipidemia. You've maybe heard the term of mixed hyperlipidemia, very specifically, not hypercholesterolemia, hyperlipidemia, or familial combined hyperlipidemia, or what we're promoting to use now in our preventive cardiology understanding of this is the combined dyslipidemia of childhood obesity. And by the end of this short final chapter, hopefully you'll understand better what this has to do with non-HDL cholesterol. Why did non-HDL cholesterol enter the scene in these most recent guidelines? And why this condition is not just about the traditional total and LDL cholesterol. And finally, how we'll identify children at risk. Why obesity poses such a strong risk for cardiovascular disease and why we recommend lipid screening can be answered in two words, basically, insulin resistance. And the prevalence of that will vary with your population. More inner city minority children are at higher risk. Overall, as Dr. Harasha just mentioned, up to 40 to 50% of obese children will have comorbid insulin resistance. And with that, we'll track their cardiovascular risk. We've known this for a long time, that obesity was related to adult risk for cardiovascular disease, but again, the story of just exactly why is unfolding in present time. This is a nice study that was published back in 2007, and we can credit the Danes and all the Scandinavians for their incredible capacity to study longitudinally for these data. They looked at all the children born. There's some 15,000 children represented in these graphs who were born in the 1930s and the 1940s, and then were followed, as they follow everyone, with their socialized medicine longitudinally with very careful health records. And they were able to show with precision that the childhood BMI between ages 7 and 13 was associated with a 1 unit increase in BMI z-score, using z-score instead of just the BMI percentile so that it's corrected for the change in age and BMI, increasing with every year of age. As children are getting older, the higher their BMI z-score, the higher the risk of cardiovascular disease in adults, all right, 30 to 40 years later in adulthood. This is important because it's such a powerful association, but it's particularly important because back in the 1930s and 1940s, we didn't have nearly the prevalence or the severity of obesity that we're dealing with in our pediatric population now. So it begins to portend the kind of tsunami of cardiovascular risk that is going to follow our current obesity epidemic. Already, some of that was starting to be picked up in Korean war victims, Vietnam War victims, and this association was looked at very systematically in what was called the PDAY study. You may have heard of it, Pathological Determinants of Atherosclerosis in Youth. And they initially didn't include obesity because this started back in the 70s, and they were thinking very much like most of us have traditionally thought about cholesterol and lipids and diabetes. But there wasn't as much obesity when they started. They went back as a second look at the data and rechecked what was the BMI on those autopsy victims. There were about 1,500 accidental death victims who were included in these analyses. And the risk factors that jumped out when they put it all together, their analyses together, and tried to study the actual presence of atherosclerotic disease. Now, we're not talking about a surrogate like a marker, but in the autopsy, the actual presence of atherosclerotic disease, here the data are shown for the coronary arteries, was associated with age, not surprisingly. It's our biggest risk factor. Hyperglycemia, which was the post-mortem equivalent surrogate for perhaps diabetic risk. Obesity, more significantly in males than in females. Women always have a little bit of protection, but it's not absolute protection. You can see how wide the confidence interval was. Hypertension, and not LDL cholesterol, but non-HDL cholesterol and then a low HDL cholesterol were the big risk factors. Of course, female gender is protective and smoking is not. And when you sort of look at these, you start to appreciate they're really, the things that I've highlighted in green here, starting to get at the metabolic syndrome, aren't they? And the obesity is a surrogate for a waist circumference. The non-HDL cholesterol, as you'll appreciate as we go on, is really a surrogate for the burden of excess triglyceride that has to be dealt with. And that pseudo-protection that it looked like being a girl was, I mean, it's not that it's pseudo, it's real protection, but it's not absolute protection. Just being a female does not protect you from the same phenomenon if you stack up those risk factors high enough. And the actual data from PDAY are shown in this slide, and you can see the increase going from the top to the bottom in both fatty streaks, and then in the lower panels, raised lesions in the coronary arteries. The increased atherosclerotic disease is reflected on this scale shown at the very bottom, going from orange to dark red to black. The increase in the prevalence of disease with age and with increasing BMI, which is shown here going from a normal under 25 up to an elevated BMI over 30. And they split the populations between the teenagers and the young adults just to demonstrate the importance of age. But I would argue that it's these risk factors, obesity being a big one, that accelerates age, and even evident in women, although it's less dramatic a progression in this early age, still a progression related to risk. So why that's happening, all right? Now we've established it's happening on our watch in pediatrics, and as Dr. Harash has shared the data with you, if we don't get on it, it's setting them up for long-term comorbid risk with cardiovascular disease. Why that happens, we are beginning to really pin down to this combined dyslipidemia of childhood obesity. And we'll talk a little bit more about that. But basically, what is happening is when you have obesity with insulin resistance, you alter the LDL metabolism, drive up the burden of LDL particles, and that's going to be better reflected by your non-HDL cholesterol than LDL cholesterol, as you'll see. What you'll see in your standard lipid profile, you'll measure triglycerides that will often be elevated. The standards that I list here are those that are used in the published tables. I have to say, because we often serve a very diverse demographic, that the cutoffs are a little different for our African American patients for reasons that have been understood genetically. There's a kind of a blunting of their triglyceride reflection of insulin resistance. So the triglycerides may not be as high in your African American patients. They still rise in direct proportion to insulin resistance if you tracked, and we have done this, if you tracked your triglyceride level with a HOMA-IR or some other reflection of insulin resistance, it will track in all children, all races, and ethnicities, but the absolute threshold might be a little bit lower. Just a caveat to not assume in your very insulin-resistant African-American child whose triglyceride might be 100, oh, they're okay, because 100 is actually very high for that child. The total HDL cholesterol is going to be low, high triglyceride, low HDL track, and you probably will have a pretty unremarkable LDL cholesterol, and that's where the problem has laid with the obesity, the cardiovascular risk of obesity, the dyslipidemia of obesity. If we're LDL-centric and just look at that, we think we're off the hook, when in fact, that combined dyslipidemia, the high triglyceride, the low HDL, is reflecting a burden of LDL that we're going to talk a little bit more about now, and it is reflected in that elevated non-HDL cholesterol. What you see on the left reflects the fact that you've shifted LDL metabolism now in the liver, and just zeroing in on many things happen when you start moving LDL metabolism around, and what basically the body's trying to do is figure out what is it going to do with all this triglyceride. We think of triglycerides and cholesterol as bad things. We absolutely have to have them, or we'd just be bags of water that would, sort of float under the the door. We need those for our membranes, we need those for form and structure and the source of energy and a lot of important metabolic pathways, but they're very toxic. We're mostly water, of course, and so it's very toxic to handle fat in a mostly aqueous environment, and the body packages them carefully. And when you've increased your burden of triglyceride, you sort of shove out the cholesterol in those packages, and you end up making these small, dense LDL particles that are very, very atherogenic. And we'll talk a little bit more about how that happens, but it follows, and it follows logically from the criteria we use for metabolic syndrome. If triglycerides are high, the HDL is low, and you have an elevated waist circumference, you've met 3 out of 5 criteria for the metabolic syndrome, which is an insulin resistance syndrome. It follows that when the triglyceride over HDL is over 3, or in children of African American ancestry, we use a lower threshold of 2.5, and your non-HDL cholesterol is elevated, starts going up over 120, certainly over 145, you're going to predict a higher burden of LDL particles. Why that matters, and this gets to the crux of why obesity causes heart disease, is if you increase the particles, you're increasing the burden, the flow, the traffic in the vessel of all these little cholesterol-laden lipoprotein packages, and you're bombarding the vessel wall. And the process of infiltrating the vessel wall happens across the lifespan, and if you overwhelm the vessel and start in preteen years through teens, always with this burden of high cholesterol, you just give more time for the disease to progress that you can see coming around clockwise around this, develops atherosclerotic thrombotic plaque. And the arrows, it's a dynamic process. There's HDL to clean things up, but by virtue of the change in lipid metabolism, your HDL is becoming less functional, and this disease is becoming more hardened, and the reverse arrows, the orange arrows going backwards to get you back towards a healthy vessel, just shrink, and it's less and less reversible as you go on in time. Another piece of evidence that argues for the importance of getting on this early in life before damage is irreversible. Now I have to talk just a little bit about LDL metabolism, about cholesterol metabolism, for you to understand this connection. How exactly does high triglyceride raise this LDL particle burden? But we don't have to say too much about it, just to explain that, as we've already said, the body's going to package this fat and cholesterol carefully. It'll package in these nice big particles that we've just been talking about. The chylomicrons are coming out of the intestine, carrying the fat and cholesterol from the intestine. They're very quickly metabolized down and gone. So they're not really around, and they're too big to have been a problem in the blood vessel anyway. They can't get into the blood vessel, they're very big. The liver starts picking up the extra triglyceride and importantly, the extra sugar that comes in when you're getting a lot of refined sugar in the diet and turned very quickly into lipid and triglyceride. The liver's picking that all up and putting it into VLDL particles, each one with one signature ApoB, and that's broken down into IDL and LDL. From another venue through the intestine, you're starting to make your HDL, has a totally different tag, no ApoB tag, and what we were looking at a moment ago, those particles that get under the skin, under the vascular skin, are only the ApoB tagged particles. So whereas we like to compartmentalize things very nicely in these LDL, IDL, VLDL particles, there's a whole continuum, and that's reflected in these kind of dominoes across the bottom. It's a continuous process of remodeling that's going on all the time. We just give snapshots of specific categories that have a range. You can see they give you an average range of size in nanometer diameter, and then below that in parentheses, the range of size that is in each of those categories. The only ones that actually get under the vessel wall are those tagged with ApoB and less than 70 nanometers in diameter. So somewhere at the lower end of VLDL down to the lowest LDL. So size matters with LDL, but all LDL is small enough to get in, all right? And we'll talk in a minute more of why size matters. Size matters in a way that it encompasses all of these particles, and remember that the triglyceride is what's driving the start of this. The triglyceride is what's driving the making, how much VLDL you're going to make and how big is it going to be. When your children are insulin sensitive, there's not that much triglyceride to process. The body's very good at handling triglycerides, so the VLDL are pretty small, and it leads, as it turns out, to bigger LDL. When there's not too much triglyceride in the LDL stays nice and big and buoyant. The HDL stays nice and big and buoyant. Those are stable particles. They work well. They balance each other, and lipid metabolism works the way it's supposed to. With insulin resistance, you have aberrant triglyceride metabolism. As the triglyceride gets driven up, the non-HDL cholesterol, what's in pink here, right? The non-HDL particles go up because your triglyceride is making more of those. And then your VLDL is big and triglyceride laden, and those big VLDL particles lead you, because of the way lipid metabolism works, to smaller LDL particles. And I've shown you a lot of them because they hang around more. This is why the big VLDL particle is too big to actually get into the vessel wall. But the big VLDL particle is what leads to the smallest LDL particle. The big VLDL particle, by virtue of having a lot of triglyceride, gets broken down by lipases that quickly whittle away its progeny and make these little tiny LDLs. And the small LDLs aren't cleared as well by the LDL receptor. In an LDL receptor defect, we talked about FH in Dr. Harash's talk, you raise your LDL because you can't clear the particles. Here you're getting the equivalent of an LDL receptor defect. These small particles aren't cleared as well, and they build up. You get more and more small particles, and that's why triglycerides driving this leads to more particle burden. It's a key connection because it's the large VLDL, you're measuring them with your non-HDL cholesterol, and that's why the non-HDL cholesterol is important, but they're not the ones that get into the vessel wall. It's the fact that those large VLDL are making lots of small particles that do, and that's how the non-HDL cholesterol is a better reflection of your LDL particle burden. And this is not just a theoretical risk based on, lab science. When in adult studies, we extrapolate a lot from adult work in pediatric preventive cardiology. In adult studies, when they look at longitudinal data like we have from the Framingham study, LDL cholesterol predicts, of course, the hazard ratio is above 1 for LDL cholesterol. That's what the whole cholesterol, empire has been built on, is in the whole statin world. But it doesn't predict as well as non-HDL cholesterol or the LDL particle, if you actually measured the LDL particle. And in fact, LDL particles plus VLDL particles don't predict a lot better because, as I said, the VLDL is a little too big to cause atherosclerosis. It's only important because it's raising your LDL particles through that conversion of big VLDL to small LDL. And then when you get the small LDL and lots of particles because they're hanging around, they're not being cleared, now you have trouble. And this trouble starts in youth. Okay, I just showed you Framingham data in adults, but we have been looking at this more carefully in pediatrics, and we know now that if you just looked at your ratio of triglyceride to HDL and your non-HDL cholesterol, and you also actually measured LDL particles, which can be measured, it's a research assay, it's not something you actually need to do because you can infer a lot from what we measure in a lipid profile. But if you actually measured it, you would be able to predict LDL size and particle burden with that ratio and with your non-HDL cholesterol. And more importantly, measures of vascular stiffness, which are very predictive of hypertension, atherosclerotic risk, and disease, go up as that triglyceride HDL ratio goes up and as your non-HDL cholesterol go up. And you may have seen the results, the long-term results from the lipid research study from Princeton, lipid research clinics, where that's where we get most of our normative data for cholesterol. It was done back in the 70s, and now they have 25-year follow-up on that. It was published just about a year ago, and they said, whoa, what a surprise, triglycerides are our biggest predictor. That was what was published. They didn't actually look at the triglyceride HDL ratio, and when we started putting these data together and asked Dr. Morrison, could you go back to your data and just see how does triglyceride HDL ratio predict? In fact, it predicted a lot better than what was published for triglyceride. It wasn't the triglyceride that was the problem. It's this shift in lipid metabolism that's raising your particle burden reflected in your triglyceride HDL ratio. And this is not extrapolation to a surrogate anymore. This is disease. These are children who had a high ratio. And then 25 years later, those are children who had heart attacks and died. So these are children we care for, and we want to prevent that. It is a preventable disease. How are we going to identify them? First thing is not to be misled by a normal or a minimally elevated LDL cholesterol. Watch for triglyceride or HDL cholesterol elevation and an elevated non-HDL cholesterol. And because these things are a reflection of insulin resistance, the signs and symptoms of the metabolic syndrome. The reason we can't just rely on cholesterol is because there's so much variability in cholesterol content because of all that dynamic lipid metabolism that we swept through very quickly here. But just to give you a flavor of the fact that at the very same LDL cholesterol, you can have larger particles and not too many of them, or you could have smaller particles and a lot of them, a much higher burden of mass bombarding the vascular wall and causing cardiovascular risk. That insulin resistance will be reflected in the child that we too often see in our own practices, where there's central weight distribution, acanthosis reflecting the hyperinsulinism to compensate for insulin resistance, hypertension, and in girls, well, in boys and girls, you start to have problems with endocrine function, hirsutism in the girls, and PCOS, gynecomastia in the boys. We have reflected what's associated with metabolic syndrome in green. If you start looking, because insulin resistance is kind of a systemic disorder, you have problems in many other things. You get NAFLD. If you start looking at liver function tests, the ALT might be elevated. If you do thyroid function, you might see the phenomenon of euthyroid hypothyroidism. TSH starts to be driven up. Even with a normal free T4, the function is beginning to be stressed. And now data are even coming out that there are cognitive sequelae of insulin resistance, that there's disordered executive function. And of course, we know increased risk of depression. So there are many things that start to happen with insulin resistance. The lipid profile is just sort of your cue. It's your marker. It's your red flag that tells you this is happening. I was able to participate in a review of the Healthy study. You may have heard of this study. All their publications are coming out now, looking at a nationwide, 42 different schools around the nation, school site intervention to improve lifestyle to prevent type 2 diabetes. And after the fact, they went back and looked at the lipid profiling, the sizing of their data. And so we were able to establish that in these healthy middle school children, here we're just looking at data in healthy sixth graders, 2,384 of them. If you divide at a waist circumference at 90th percentile, you can see the effect of insulin resistance play out. It's a very sensitive indicator for your triglycerides going up significantly, your HDL going down. Your LDL cholesterol, there's a little bit of an upward burden, but it's not nearly as dramatic as the increase in the non-HDL cholesterol and as the increase in LDL particles. You can see the size begins to go down and the LDL particle burden goes up significantly, both because the large LDL particles are going down, moving from left to the right, and the small LDL particles catapult up. Normal insulin-sensitive lipid metabolism, you just don't have much small LDL. They don't get made because the body doesn't have to deal with that much triglyceride. As soon as you put that burden of ectopic visceral central adiposity on a system, you've driven the liver into a very aberrant kind of LDL generation that's very atherogenic. Knowing that these things all related to the LDL particle burden, they were all thrown into a model, and the multivariate model that came out for the best prediction of your LDL particle included waist circumference, very significantly, the triglyceride over HDL ratio, your non-HDL cholesterol, and HOMA-IR if you're screening insulin and glucose and can generate that measure of insulin resistance. These are listed here so that you get a sense you don't need to be sending the particle burden. Sometimes we do this in a preventive cardiology clinic to get better insight into how concerned to be about some of the lipids that we're measuring in kids. But in a general pediatric practice, all of this is evident on your exam and with a standard lipid profile. This is added, although you've already gone over it with Ashraf in some detail, only to emphasize that we have our target levels. What the new guidelines are listing as high are really very high. We're putting it up at 95th percentile for the high thresholds, lower than 5th percentile in terms of what would be normal for the HDL. And in adults, we start treating when people are moving over 50th percentile. So we're setting the bar higher in pediatrics. And what we're talking about treatment is lifestyle, 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 because the threshold is set even higher at the 99th percentile to start talking about drugs. So that means 1% of kids. Not a lot of children are going to be eligible for drugs. The 99th percentile being over 160, and even there we say you also have to have a family history. It has to be over 99.8th percentile, somewhere around 190. Not a lot of kids fall in that category, fortunately, to justify statins without other risk factors. What's interesting, and what you hopefully understand a little bit better right now, is that they have this convoluted set of algorithms, and the LDL over 130 could still justify consideration of drug adjunct pharmacologic therapy if there were other risk factors. That's where you're getting at the LDL particle burden. Those other risk factors that are listed, all those inflammatory risk factors that were in the tables that Dr. Harashar has already gone over, are the things that raise your LDL particle burden. You've already heard about lifestyle therapy. It really does work because if you can, triglycerides are very lifestyle sensitive. If you can lower the burden of triglycerides, improve insulin sensitivity, you improve your LDL quality, and you improve this problem of the combined dyslipidemia of childhood obesity. So, in summary, obesity unequivocally accelerates cardiovascular disease in children who are insulin resistant. That risk is mediated by an increase in LDL particles. It might not be reflected in the LDL cholesterol, but will in the non-HDL cholesterol and in that triglyceride-HDL ratio. These are children who will have features of insulin resistance clinically and in their biochemical analyses, and therapeutic lifestyle change really does work on this phenotype. Rarely would adjunct medicine come into play. We've been working with that pedal group to understand this phenomenon better, and we're working now through the Pediatric Heart Network, and what's kind of a quantum shift for that network. It's a consortium of centers that have traditionally focused on congenital heart disease. It's a quantum shift for them to be interested in a preventive problem now, and they're supporting efforts to try to study this very phenomenon. And so hopefully next time we talk to you about it, we'll have some more information that gives you better evidence-based guidelines on how to best treat it. Thank you so much, and thanks for your patience.